in the idea of giving you an overview and where we come from in CF with research and clinical research and where things are probably heading. Okay, I have to disclose that I had received funding from Vertex for an observational study that I did and I initiated. The objectives of this talk is first to kind of lay out a little bit where the whole idea of this high fat, high calorie diet in CF comes from. Then I want to give you a bit of a know-how how to assess nutritional status. Want to give you some data about the rates of obesity in CF and how the nutritional status changes with CFTR modulation. And then hopefully what you may find useful a little bit for your basic understanding, because in the end I'm a physiologist too, is what do you actually need to know about how fat is absorbed and how important fat absorption is in CF. First of all, we go a little bit back in history and see where this whole concept of high fat, high caloric intake comes from. And for all of you who know all these things, I do apologize maybe for some repeat, but I find always it's good to get a little bit on overview before talking about in more detail. So there had been a major study done by Mary Corey, who was a biostatistician here at Sick Kids in Toronto. And they did compare two cohorts of CF patients, and one was in Toronto and one was in Boston. And when they did that because it was a similar setting, both on the East Coast. And when they did compare these both cohorts, they found a major survival difference of a mean 50% survival difference of 9 years between these two cohorts. And then they were questioning how come. And what you see here, I think you see also my mouse, these are survival graphs. Here's the age of a patient as it goes older, the percent of these patients at that age surviving. And the higher this curve is, the better, kind of the higher chance you have to live longer. And you see Toronto by far had the best survival, and even compared to the rest of Canada, so it's not a Canadian thing, it was a Toronto thing, Boston or the US. And when they did compare, they said, hey, wow, both centers have a really high volume of patients, 500. When they compared the cohort, they had same lung function. But the main difference they kind of identified was that in Toronto at that point, there was a promotion of a high-fat diet accompanied by an increased number of enzymes that you have to take with that. In Boston, a low-fat diet was promoted also with enzymes. I think the whole idea about before not going into too much fat intake came from the observation that before enzymes came to market, CF patients had these terrible steatorrhea, diarrhea, fat loss, foul-smelling stools. And I think here the idea was born, the less fat you put in that person, the less of that diarrhea you have. In opposite, Toronto said no, more calorie and is better, and fat is a good calorie kind of carrier. So they tried to overcome that fat losing by just giving more and giving more enzymes. And they did that successfully as per the survival. And there was a lot of studies by all my previous mentors. Peter Dury, who died last year, was one of them. Paul Penchard's, Dinah Kalnin's, a very famous dietitian here at Sick Kids, who did a lot of studies to try to explain why patients with cystic fibrosis are in such a difficult nutritional status, and why in the end they need an increase in calories compared to non-CF subjects. And at the end of many different studies, they came up with a model saying, yeah, there is probably a component of patients who always have some sort of inflammation or feeling sick, do not take enough food in, and that may be true for really sick patients. Then they found out that because of the lung disease, the ongoing inflammation, ongoing attempts to use your muscles to breathe more, there's an increase in energy needs that the body just has. Infection contributes to that, that if a body is infected, immediately your energy needs go up. So putting all these different facts together, they came up with the idea that if you don't put enough food into that person, there is unavoidably an energy deficit. So all our approaches at that point is to make sure that CF patients get enough energy from early on, high caloric, and as I shown you before, high fat. And doing that in the 80s and 90s, people were pretty successful. There came more studies out during the course of time promoting the idea that weight and nutrition is immediately associated with better lung function or better lung health, and that then in the end translate to longevity of patients. And there's a German study looking at they did a quality project with their first registry data. And when they looked at their patients' data, and here's the FEV1 lung function, the percent predicted, and the different ages, and they separated these people, these CF patients, by those with normal weight and had a negative finding of Pseudomonas, so they put that Pseudomonas now also in that mix, or normal weight and a positive culture for Pseudomonas, so an infection, and compared to those who have not normal weight, who are malnourished, with or without having Pseudomonas, you clearly see that here these normal weight CF patients, actually with or without Pseudomonas, do much better in terms of lung function than their malnourished kind of colleagues. And there are a couple of more of these kind of studies using registry data to really demonstrate that nutrition is tightly connected with lung health measured in lung function. And that led in to like a committee that was organized and initiated by the CF Foundation in the US to look at the clinical practice guidelines, and that was headed by Starlings from CHOP. And they had, the US has the biggest CF registry with 10,000 patients, and they do these yearly reports, as you know, like as all countries do. And when they did that from 1994 to 2000, when they looked at their registry data from CF patients, they saw that when looking at the BMI, which is the body mass index, and I explain later how that is calculated, to lung function, they see that there's a clear relation that the higher the body mass index is in this cohort, the better the lung function. And this is measured only in adult patients. You know that in kids, you're all adults, but you have probably seen that when you were a child with CF, that when you do assess weight and height in children, there's a change over age, right? As the kid grows, also the body mass index changes. But in adults, in that age group, we assume that everybody has an ideal body mass between 22 and 25. So this is where this whole concept about more BMI, more nutrition is better for CF patients. And this can be achieved as this famous study from Toronto, Boston, with high caloric, high energy, high fat diets. So before then, I now continue, because I already thrown here some terms like body mass index. I want to just give you a little bit an overview. So also in that Stallings Guidelines Committee, they said that using weight to height percentiles, that something that we have done, we do a lot in pediatrics, and people have done so far, they said is too cumbersome. And that they suggested and recommended that instead people in CF centers should use a body mass index. And the body mass index is a very simple formula which measures your weight in kilogram, and then you divide that by your height in meters square. So in the end, like in this cartoon joke, it measures how much mass, body mass, you have compared to your overall body height. And people for the non-CF world, but now probably more and more it will apply also to the CF world, have defined cutoffs of the body mass index in the adults to range somebody as being like malnourished or undernourished. Normally here in the red, the person in a normal body mass, normal nutrition, those who are a little bit overweight, and those over 30 who are considered obese. And we all live in a world where there's a lot of information on internet and television, and we all know that in North America there's a great concern about increasing obesity and overweight status, not only in adults but also in children, and there's a lot of campaigns and initiatives trying to overcome that. But body mass index does not tell you what type of tissue your body has. It only measures how much mass, if you want, you bring to the scale. So here in this nice cartoon, you know, like these both people have the same weight, but one is nice and muscular, and the other person is less muscular and has more kind of fat mass. And the question now becomes, does that matter? You know, for the looks, you know, it probably does, but also for health risks, does that matter? And I want to continue on that and just showing you the body composition. When we look at that, is usually divided into muscle mass, which is about 40% in a man and about 35% in a woman. Then the measuring of essential fat and storage fat. You know that we have, when we age, like when you are born as a baby, you have more of these essential fat, and fat has a much different role when you are little. Like I'm a pediatrician, when you're an infant, you need that fat in order to kind of regulate temperature, for example. But the older you get, your essential fat diminishes. And you have then kind of your leftovers as storage fat, so 15%, 12% in women. And the women have a little bit more essential fat as well. And the rest is bones. And then there's other tissues like connective tissues, for example. So these are healthy ranges. But how can we measure body composition? How can we measure between these different composites of our body mass, if you want? And one very elegant way, which we do here in Toronto, also with our in a different nutrition and obese program, is using a bot pot. And a bot pot is like here that I stole from the internet. It's a big chamber that can close, so it gets completely closed, and it measures a certain air volume in that chamber. And the body that goes into that chamber, here this nice young man, displaces, while he sits in there, displaces that air that is in the chamber. There will be also a calculation of CO2 that is exhaled while being in the chamber. So there's a little bit calculation and measurement going on in this chamber. It's a very brief measurements, I think a couple of minutes only, you know, to not get claustrophobic in that chamber. And then you get good readings, repeatable readings about fat mass and non-fat mass. It cannot distinguish between muscle, bones, and in body mass. It can only say fat or non-fat. The gold standard is a DEXA scan, which some of you may have had to look at your bones. And this is how we mainly use it. This is measuring the density of your tissues. And it's an X-ray of the whole body, and by looking at your bone density using radiological measures, people can now say, do you have a bone density problem or not? But while it looks for bones, so this is how it's mainly used, it can also measure the density of all the other tissues. And by doing that, by differentiating that, it's a special software, it can say here like how much fat versus muscle versus bone you have, and gives you a pretty good accurate measurement of body composition. Another way to measure body composition is by the bioelectrical impedance. And this uses, I try to use a simple picture, electrodes that clips on your hands and feet. So like one hand and one foot, and it applies current and from one kind of electrode, and then the current arrives to the other electrode, and how much current kind of gets lost on the way and how strong that current is, it gives feedback about how much fat that current has to travel through and how dense the tissue is. And by doing that between here and here, that would be only kind of very small distance. It actually also measures between the hand and the foot. These things work, all of these tests work because people have done outside of CF a lot of studies where they try to establish what is a normal result for like a normal body composite person. And people have also done studies for non-CF patients, like healthy controls, or people with some other diseases, where they compare one method over the other. All of these methods are currently being employed in different studies, in different centers. All of the DEXA scan is the gold standard, but there's a radiation kind of side effects to that. The bioelectrical impedance has probably the least side effect if you want, but may have kind of problems with, can that really be without errors all of the time? Thinking about, you may remember that you have similar testing done as a CF patient using iontophoresis current. So salt content may influence this test. The BOT port, I already talked about the limitation, may not give you the same accurate reading. It just gives you the fat mass and the non-fat mass. So how is now you hopefully understand a little bit all these different terms and can sort that a little bit in your head when coming now forward with how is the nutritional status changing in CF, and hopefully that gives you some food for thoughts in your discussions. There are not many studies yet, but there's an increasing observation to be made. One was in Pittsburgh, where they looked on 226 patients, and I must admit these are not adults, these are pediatric patients, and they plotted those along a graph here, age and body mass index. And by definition, if the body mass index is in these high percentiles, you are defined as being obese and overweight. That may not be correct for everybody, but remember I talked about body composition, but in general, this is how people look at these percentiles. Whereas when you have a body mass index at the low percentile, remember, this skin man on the graph, then you're more being associated with an increased malnutrition risk. So when they did that, here the overweight is the triangle, the obese is the squares. Look here, all these people would fall in these top percentiles. They found that 23% of their population, CF population, is actually overweight or obese. They did mention that most of them are actually those who are pancreatic sufficient, but nevertheless, they also had a couple of the pancreatic insufficient in that group. And until that time, that was actually unheard of, that CF patient can be obese. In Toronto, we have a very large adult cohort, and Anne Stevenson, who also does our CF Canada or CF registry, using the CF Canada registry every year. So they publish on 900 adult patients and a longer time period, and they looked at different decades. And they had like a 90s, 2000, and 2010. And they looked here, this is kind of plotted here, 90s, 91 to 99, and then above 2000. And they looked at the distribution, here's a body mass index, of the body mass in that cohort, in that year, or excuse me, for that decade. And over the last decade, so the distribution of the BMI has shifted to the right. So patients in general, so the average BMI increased, which is between like 20 to 21, 22. Not much, but enough to make it significant. But increasing BMI in the end is a good thing. 21, 22 is all in the good range. But they also noticed, looking at the data, that the proportion of underweight CF patients changed, actually decreased from 20% to 11%, which is a perfect thing. That is kind of having achieved the aim of having everybody in a good nutritional status. But maybe too good of an approach, because the proportion of overweight patients also changed from 7 to 18%. So that may have overshot that a little bit. In their own cohort, then they said, okay, does that matter? So they looked at lung function. I didn't show you that. And they, patient with the obese kind of range, they did not have worse lung function. And they actually also had like a really good lung function range. So they couldn't, Anne Stevenson and her team, they couldn't say that those who are in this top BMI range had worse lung disease. They could not say that. But when they looked at other problems associated with obesity, for example, hyperlipidemia, like how much fat you have in your bloodstream, that may then increase your risk for cardiovascular disease in the end, they did show that there's a change in those with obese. So I show you here, these are this group, the underweight, the adequate weight, the overweight, and the obese. And they had these many patients in these groups. So not many in the obese, a little bit more in the overweight. And when you look at the triglycerides, and if you don't understand how much kind of is normal, but they sorted that for you, the high and the normal ones, you see that the percentage that have actually high levels, even though there's only 5 in a group, is higher than those in the normal or underweight group. When we looked at cholesterol level, I think cholesterol level is something people have more commonly heard about as being a marker for health in general. You see that the cholesterol level in those who are overweight, obese increased. And again, those who have high, like 5.2 is a really good high level, there's none in the underweight group, but there's an increase in those with overweight and obese, suggesting now there is an emerge of CF patients that go in the wrong kind of direction, and with increasing risk factors associated with obesity. But as I said before, body mass index may not capture the entire picture, because you may have a good body mass index as a high body mass index as a CF patient, but you may be one of the super athlete, doing high intensity sport all the time, having a lot of muscle mass. So your risk may be different than somebody who doesn't do that. So Alvarez is a dietitian, a nutritionalist, actually, I have to say, from Texas. And she's coming out with these really nice studies now. And this may be somebody, if you continue with that topic, to think about inviting to your talks and to your meetings. So she did look at a different group and defined those who have a body mass index of less than 25, which was 25 is our normal cutoff, and 25 and higher goes into overweight, but then who had on assessment of their body composition a body fat of more than 30% as a normal weight obesity group. We said, okay, they have a normal BMI, but they have a little bit more fat than normal on the body composition. And when they looked at their CF population, they identified 30% of those actually had that. They had a normal BMI, but an increased body fat. And then they looked at their lung function and grouped these people together. And what they show here, sorry, I go on the lower graph first. If you look at the body fat percentage here, which increases over this axis, and the lung function, you see there's an inverse correlation. So the more body fat you have, the less of a lung function these patients had. And opposite, saying that those who had normal body mass index, but a good amount of fat-free mass, so the opposite of the body fat, so lean mass, fat-free mass, with higher indices, the lung function was better in this cohort. So that was one single center cohort, and there's always something that we researchers always say, be aware that this may just have happened in this one single cohort, and you need always to replicate these data in somewhere else, right? Before to generalize. But nevertheless, it's an interesting observation, and it raises exactly the point of, is body mass index the right measure? And do we kind of miss some people at risk earlier on? Or, like I always do the example to that kind of a sports person with a high BMI, or maybe wrongly assign risk to somebody who has actually good muscular mass. So why all these things happening in a classic CF patient without any current CFTR modulator treatment? We have done now a study looking at what happens when CF patients go on a CFTR modulator, what happens to the nutrition. And we looked at patients with G551D when they started on Calorie ivacaftor. And before, this is maybe just to introduce that concept, before people have, in all the Vertex studies, phase 2, phase 3, Calorie or Cambi, people have noticed that there's a great improvement in weight and body mass index in CF patients going on this modulator therapy. And this is a waterfall plot. It helps to nicely show they're not individual patients, but they are a little bit grouped together in these kind of bins. And they give you a little, a sort of a range of, some people really had a good weight improvement, but not many. Many people had, sorry, I kind of switched too fast. Many people had that in between weight improvement, which was greatly significant. And many people that they saw that, but some also, it's not everybody had a weight increase. Some people did not increase their BMI. And so our study was now using the Calorie coming into Canada. We had a little bit delay. This is our health policy is different than the US. And we wanted to understand the biology of that weight gain that people reported in CF patients with G551D and ivacaftor. So we measured a couple of things, resting energy expenditure, which was always thought to be high. And I'm not showing these data just to not confuse too much the issues. We measured the body composition. We measured pancreas function, and we measured some lab biochemical markers in blood. And we did use these spot pods because it was available to us, had no radiation, and we could repeatedly do. And we thought that would be a good measure to do so. And we had 18 patients with this G554D, and there were adults and there were kids. We had everybody who started on the drug, different mutations. And we also had 3 pancreatic sufficient patients. And weight Z-score, BMI Z-score, they were BMI was in normal range. We didn't have really severe malnourished patient in that cohort to begin with. We looked at the weight Z-score. That's a measure for more used in kids. The Z-score always tells you how much away from normal you are. So a negative Z-score is always bad in CF. It shows you're underweight. A weight Z-score of going up is actually an improvement. If you're too up, you're too big in your weight. So this is a nice increase when from starting ivacaftor or Calorie, and then a couple of months, 6 months, 12 months, and 24 months later. Same, the BMI Z-score, like how it is, again, looking at the percentiles, went up nicely and stayed up. And this was confirming what all the other studies have shown before. We then looked at the change in fat-free mass over the time. And here we look at difference between when patients were before the drug or 6 months or 12 months or 24 months after the drug. So all these dots are single patients and they measure differences. So 0 mark here meant no change. And everything negative means it changed, it decreased, everything positive increased. So we had a couple of super increaser in that cohort, but then when we looked at the age, so sorry that it got here a little bit stuck together, these were all our kiddies, these were all our patients under 19. And in this age group and change in fat-free mass, these are all kids that's still growing, is actually to be expected. So we can't really say Kaleido did that. Where these three kind of were our young kiddies, where all the other ones who were over 19, you see they have around 0. Some increased a little bit, some decreased. So not, if you look at the means here, no really significant change in fat-free mass. When we looked at the fat mass, then we see in the end that here, this is again the difference to the pre-drug, 6 months, 12 months, 24 months later, we see that there's an increase in, fat-free mass. I'm just talking to you and realizing this is the same slide I showed you. So I apologize, this would be fat mass, so it's a wrong slide, so ignore that, I just explained that. So when we looked at the fat mass and here the fat percentage change, so overall percentage of fat in body composition, we saw that there was a change from the pre to the post 6 months, so it's all positive. And that stayed up over the course of the 2 years observation. And these X's were our young children, and then these dotted symbols are our adult patients. And no matter if you were kid or adult, there was an increase in your fat percentage. So we did other measures, but we did come out with that and gave talks to the North American CF community saying there appears to be that the weight increase on patients on Kaleido is associated with an increase in fat mass and fat percentage rather than lean body mass. There were 2 other studies in parallel. One is already published that was also done by Stallings at CHOP. She did not see that. She did also see similar other things, change in resting energy percentage, energy expenditure, but she did not see that increase in fat mass. And she did the beta test, she used the DEXA scan. But we also had another person doing a similar study in Australia. And she did a study on Delta F508 patient going on Orkambi. And she used the bioelectric impedance measurement. And she did show also, similar to us, that there's an increase in fat mass, fat percentage. This increase seems to be early and that not anymore. So there's no further increase in 2 years here follow-up. So there's not an ongoing increase, which is reassuring. So this is something to maybe think about. Is this something that is worrisome? Is it something to be expected? But I think it's a new observation we all made. When we looked at our patients on Kaleido or Orkambi treatment, one thing that I noticed was that I think I'm overdrawing a little bit. I can stop here, Melissa, you tell me. I'm actually said everything and I could give a little bit background of absorption. I realize it's 3:40 right now.
Yeah, I think we need to move on to question and answer, if that's okay, if you want to just give some concluding remarks.
Yep, absolutely. So yes, so I think I highlighted everything that I wanted to say, except for one more thing. My colleague in Australia, he did a study in children, and he did talk about diet habits, and sorted their children into those who had many energy dense and poor nutrition, and the nutrient patient and subjects or patients with nutrient dense diets mainly. And he found that When CF kids are compared to an age-matched control, their energy intake is higher, which is expected and wanted. The fat intake, the percentage is the same, but the energy-dense, poor nutrient food was altogether here 45% versus 30% higher in the CF group. So of all the high calorie intake, it was more of the nutrient poor foods being intaken by CF kids compared to their controls. So in the end, I think we are experiencing a shift in the nutritional status of CF patients, away more and more away from malnutrition, maybe to obesity. I think CFTR modulator will probably add to this phenomenon. I think at one point it will be time to look for new diet recommendation and maybe also different eating habits. These kids and CF patients and adults have been told to eat kind of hard and furious all the time, and it's really difficult to break habits. Regular exercise may be one of the key ingredients to overcome that obesity wave and to promote lean body mass. And I think in the interim, until we have sorted all these things out, I think dietary consultation should be very individual to current needs of CF patients. Maybe different for a patient who's good nourished, going on a modulated therapy, compared to somebody who's struggling with weight and being malnourished. So the high calorie, high dense kind of approach may not suit everybody anymore. And thank you very much for your patience. Sorry that I overdrew a little bit.